So let me begin by introducing this symposium. And my disclosures are right here. I serve on Marinas DSMB. I've served on NIH panels, UVA Brain Institute, and I'm on boards of ILAE and other organizations. And these do relate to our topic at hand. As many of you would be aware that World Health Assembly, which is the organ of World Health Organization, WHO, recently announced that it would like to reduce the treatment gap in epilepsy globally, all across the world. And this is called, in a bureaucratic language, Intersectorial Global Action Plan on Epilepsy and Other Neurological Disorders, which was adopted by World Health Organization. And one of the goals that International League Against Epilepsy has pushed for is, and it's a bold, audacious goal, what we call 90, 80, and 70. That is, we want to have 90% of patients, all people across the world, diagnosed with epilepsy, 80% of them on medications, and 70% seizure-free. Theoretically, it's possible. Practically, it's a big, big, big challenge. When WHO announced this, I was speaking to them, and I said, what do you think of treatment gap in United States? And their official position was, US is a very rich country, and there is no problem in US. So, and I said, thank you, but I think that things are a bit different. And this session actually also grows out of several special interest group sessions that have been occurring and other sessions that have been occurring at American Epilepsy Society meeting, where groups of individuals, a lot of young epileptologists have been very interested in this issue of healthcare disparities, epilepsy healthcare disparities in United States. And when I heard them, many of them seemed to suggest that the leadership was not aware or didn't really focus on it. Contrary to the belief, I think the leadership of American Epilepsy Society is deeply committed to healthcare equities. And I think that will be obvious to you, not just from this program, but all across next programs for until Tuesday. The number of sessions that relate to healthcare equities is numerous. And so this is just one of many programs on epilepsy healthcare disparities. So let me just point to you. Most of you know this literature. If you look at things that are easily measured, infant mortality rate varies by race and ethnicity. It's twice as much in Black Americans as in white American. This is 2013. These numbers haven't changed much. Also, geographically, where you live determines how long you live. This is a very nice illustration of how geography matters, right? So just outside New Orleans, where you live, or in Kansas City, where you live just around these two cities will determine your life expectancy. So just geography is your healthcare outcome. And I don't think I need to justify this, but I will. Why should we care for equity? I think this gets challenged sometimes outside in non-academic circles. First is very basic moral principle that we provide equal worth to all people. That's a core human right, universal human right, that all human life have same value. People like to talk about costs, and is it costly to address these problems? Actually, it saves cost. There's a lot of literature, health economics literature, that when you address health inequities, you reduce the cost for healthcare systems. And you can see the cost to the insurers or to other public health systems. Obviously, for our economy, healthy and productive population is important and really helps grow our economy. And finally, Of course, there is military is interested because they want healthy war fighters. So there's a lot of work done by Institute of Medicine, national academies, around healthcare disparities. The original report was 2003. I've just picked up one report, and one of the reasons why physicians get daunted by this problem is because it's beyond their control. We are all used to seeing a patient, finding their problem, diagnosing it, and then treating it with the medication. But healthcare disparities is a social determinant of health where many, many social factors, and they're all laid out in this diagram in front of you, impact it. But the real truth is that physicians are also leaders and thought leaders and action leaders. And in many of these community action programs, we need to be able to engage our communities to be able to organize to improve healthcare outcomes. And it is in engaging our communities that we'll be able to improve outcomes. So there is a bit of a shift in the order. The first speaker coming up is Dr. Mel Atine. And he's from the New York Medical College, and he's done a lot of work on healthcare disparities amongst Black Americans.
Good morning, everyone. So I'm going to spend the next 15, 20 minutes or so speaking to you about epilepsy in Black Americans, and particularly, I always like to focus on strategies to eliminate disparities, and not just kind of saying how bad things are, but there is an actual way to move forward. I have no disclosures. So objectives, by the end of this talk, you should be able to understand how structural and social determinants of neurological disorders contribute to disparities in epilepsy outcomes. And you should also be able to demonstrate an understanding of how to address structural and social determinants of epilepsy outcomes in Black Americans. I'll start by defining some basic principles, what health disparity means. This is a difference in health that is closely linked with social or economic disadvantage. It negatively affects groups of people who have systematically experienced greater social or economic obstacles to health. Those obstacles stem from characteristics historically linked to discrimination or exclusion. What you see below is a figure that goes over the coin model for understanding privilege and advantage in the United States. The coin itself is a system of inequality, like a structure that produces and maintains inequality. These could be sexism, racism, ableism. People could be on the top of the coin. If you're on top of the coin, then you have an advantage. A lot of times that advantage is unearned. You just have it because of who you are. If you're on the bottom of the coin, you're underprivileged, you're disadvantaged. Again, you have this disadvantage not because you've earned it, but it's because of who you happen to be. And what you see here is there are multiple coins. A person could be on top of one coin, on the bottom of another coin. And really, it all depends on your various identities. And I like to go over this coin model because it's a one way of actually looking at yourself and saying which of these coins am I on top of, which of these coins am I on the bottom of, and also look at your patients through that same lens. And by understanding the various coins or the various advantages and disadvantages your patient might have, you'll have a much better understanding of that patient and what challenges they've had to actually getting quality health. Many people are on the bottom of many coins, and we call this intersectionality, where because of being on the bottom of so many coins, the person will have a lot more, may have a lot more challenges in life. Now, I was in a group once with people who have disabilities, and they said, well, why can't the coin just be on its side? Yes, it's hard to balance a coin on the side, and you'll say, it might be hard, but we've gone to the moon. I think we can actually do it. Neuroequity is fair and just opportunity to attain the highest level of neurologic health for all people. To achieve neuroequity will require valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities. We want to address obstacles to optimize neurologic health and healthcare. I have some of those obstacles listed below. These could be poverty, discrimination and their consequences, powerlessness, requires addressing structural and social determinants of health. And also, one of the most important things is acknowledging and addressing racism as a threat to public health. There are many ways to measure neuro inequities, incidence and prevalence of disease, disability-adjusted life years, premature or excessive mortality, as well as quality of life. Now, I know we hear these terms a lot, structural determinants of health. A lot of people probably wouldn't be able to say, what are you even talking about when you say structural determinants of health? I lifted some here. Structural determinants of health are social, economic, and political mechanisms which generate inequities in our society. From the government process, think about slavery, think about Jim Crow laws, the 13th Amendment, redlining, and the GI Bill, how it was actually introduced and brought out to the public. Also think about economic and social policies that affect pay, working conditions, housing, and education. The structural determinants of health are the root causes of health inequities because they shape the quality of the social determinants of health experienced by people in their neighborhoods and communities. They affect what resources those people have access to. And when those structural factors are present that threaten the health of communities, it's critical to actually address those factors. And if you get nothing else from this talk, what I would say is, I want you to understand this, that structural factors require structural solutions. And I'll give you a quick example that's not on my slides, which I just thought about when Dr. Kapoor was speaking, was the idea of curb cutting. When people with disabilities, particularly who required wheelchairs, couldn't access sidewalks, they were not having access, that negatively impacted their health. When curbs started being cut to give those folks access, what did it do? It didn't just give them access. It actually gave people who had strollers access. It actually gave people who were trying to get shopping carts into the supermarket, kept you from dumping your groceries over the floor. So all of society actually benefited. So by actually addressing the health disparities, the entire United States will actually benefit overall. Now, here are the social determinants of health that we often hear about, and it's important to be familiar with those. There are the places where you live, work, grow, worship, and some of the categories here: neighborhood and physical environment, economic stability, education, food, access to food, what types of food you have access to, community and social context, including social integration, your support systems, discrimination, and of course the healthcare system and what types of access to care that the individual has. These factors all contribute to morbidity, mortality, and life expectancy. And the thing to think about for this audience is which of these factors actually impact the outcomes of our patients with epilepsy, and what strategies will you implement to actually address those factors. And of course, I'm going to say social factors require social solutions, but structural factors will also contribute to actually eliminating those social factors. This is the weathering hypothesis, which actually explains how these structural factors and these social determinants weigh on these minoritized groups throughout their lifetime. This is the cumulative effect of chronic stress and the neuroendocrine response through constant exposure to psychosocial stressors. So your hypothalamic adrenal axis, pituitary adrenal axis, is constantly being set off. So you've got these high levels of cortisol. What does that lead to? High blood pressure, obesity, diabetes, all these things that have been tagged to the Black community, and really it actually comes down to these structural and social factors that have actually led to those disparities. Cultural competence, we hear about this a lot. That's the knowledge of the culturally specific beliefs and attitudes of your patients, appreciating their beliefs, and even if it's not scientifically grounded, and understanding how to use those beliefs to actually optimize those patients' care. And I don't stress cultural competence as much when I teach medical students. I like to stress cultural humility because I hate it when somebody says, well, I've gone to such and such place, so I know those people. Not really. You know the few people that you met, and you know a little bit about them. So cultural humility is really having that constant learning and saying, yes, I'm going to be humble when I come to my patient and learn from them. They're going to teach you about their life and their disease. And also, we need to have structural competence. And what's that? Well, I just gave you some of the tools for it. What are those structural factors that are contributing to the health of your patient? And what do we do actually how do you actually tailor your care to the patient to overcome those structural barriers? Oftentimes we hear that race is a social construct, and every time I give a talk, somebody says, well, if it's a social construct, why are we even talking about it? And why do we measure it? Why are you saying that we should when we do a research or clinical trial, we should measure race? We should be talking about race. Well, the reason is because each time we check, we find a big, big problem. For example, when Dr. Sadi and her colleagues looked at access to neurologists, what they found was black patients were 30% less likely to see a neurologist. And I'll just tell you what I've started doing recently is I've been looking at the neurology journal, I'm reading each paper, and I have my medical students look at it and say, did they talk about race? Did they address it appropriately? If not, we write a comment, send it to these authors so that they can start to know this is important and you have to start reporting it. And if you don't have access to a neurologist, guess what? You're not gonna have access to an epileptologist. That's the gateway to the epileptologist. I put access to EEG, I slipped it up there only because so many of our black patients can't even get a good EEG. So you're not even getting a good reading. How are you gonna plan for surgery? Go into somebody's brain when you can't even get a good EEG reading because the electrodes that have been designed don't actually address the entire population. Access to epilepsy surgery. We've known this for many, many years. We've known black patients are less likely to have epilepsy surgery even if they've seen the epileptologist. Access to vagal nerve stimulator, RNS, DBS, decreased access across the board. And we know that not having your seizures well taken care of, having ongoing convulsions, is going to increase your likelihood of having SUDEP, sudden unexpected death from epilepsy. And this is a paper by one of my former co-fellows, Dr. Friedman, but the lead author is Dr. Karlovich. And they looked at SUDEP deaths in San Diego. And what they found was that the black patients made up about 10.9% of the SUDEP deaths and 13.8% of the non-SUDEP deaths. And so that comes out to about 12.5% of epilepsy-related deaths. And you're gonna say, well, actually, that's about what the US population is. So I said, okay, well, let's do a little bit more digging. So look at the San Diego census data. Black people make up 5% of San Diego. And so what that tells me is that we're actually at about double the mortality rate in these epilepsy patients, and that was not reported in the paper. Now we go to, so how are we gonna address this gap? How are we gonna address these problems in epilepsy care? This is the table looking at US population, medical school enrollment, neurology fellows, epilepsy fellows, US neurologists, and you see across the board, we've known this for a long time. Black epilepsy fellows, 4%. In the population, about 13% of the US population. So the numbers are dramatically underrepresented. When you hear the words underrepresented in medicine, that's what we mean by that. And there are many factors that have contributed to these low numbers of black neurologists, black epileptologists. One of those factors that many believe is this Flexner report from the early 1900s. When Dr. Flexner went around, went through all the medical schools and said, this school is good, this school is no good. At that time, most medical schools were about a year or so long anyway. The education was not good, it's true, it was not optimal. But Dr. Flexner also had an opinion about black people in medicine. African-American physicians should be trained in hygiene rather than surgery and should primarily serve as sanitarians whose purpose is protecting whites from common diseases like tuberculosis. And Flexner actually also acknowledged that black patients, or he believed, black patients should be cared for by black doctors. Despite that acknowledgement, what happened from the Flexner report? 55% of the medical schools in the US were closed. 71% of the black medical schools were closed, the HBCUs. There were only 7 at the time. He closed 5, despite saying that, we know that we want these black doctors to take care of these black patients. And so you had 2 medical schools to take care of the 10 million black people in America. And mind you, this is during the Jim Crow era, right? So we know that separate but equal was the law of the land. This is a rejection letter from Emory University, which I'm sure many of you have seen on the internet, from Dr. Hood. And it says, you're not going to be accepted because you're black. This is in 1959. Remember, Brown versus the Board of Ed was 1954. We just had a major Supreme Court decision this year, and across the board, all I'm hearing is, oh my God, we have to be in compliance with the Supreme Court. 5 years after Brown versus the Board of Ed, people were still issuing letters saying, you can't get in here because you're black. A few years ago, Emory apologized to Dr. Hood. Yes, Dr. Hood, because he did go to another medical school that was accepting black people into the school, and they actually honored him in a nice ceremony. And a lot of these things happened, we know, after COVID. A lot of people started realizing, oh yeah, there are disparities, there are problems in America, and a lot of things started to come to fruition. But the AAMC did issue a statement after the murder of George Floyd and saying, yes, the Flexner report did harm black communities, and because of that, they actually removed the really biggest honor, biggest award from the AAMC was the Flexner Award, and they have changed the name for that, partly for that reason. Epilepsy trainees, we covered this a little bit already. Right now, the latest class of epilepsy fellows, 5.4% of them are black compared to 13.6% of the US population. And now we're gonna talk about how do we patch the holes in these pipeline. So yes, we wanna have increased number of URIM or black people in epilepsy. What does that do? It increases access to epilepsy care in underserved communities. What does that do? Improves epilepsy outcomes in those communities, narrowing those treatment gaps. Increased access to diversity in clinical trials, right? Because a lot of times black, Hispanic patients are not part of these clinical trials, and so now you're gonna give them that access. So now you're gonna have more useful data as you treat these patients. What does that also do? More mentoring opportunities in those communities, because now you've got the black doctors, black epileptologists, and now you're addressing, it's a structural solution to this problem. And you can't wait till medical school or till residency to start addressing the problem. It starts from K through 12. We have to have programs where we're going back into the communities from the very beginning. In college, shadowing experiences. Huge disparities in access to shadowing and research. I mean, I interview for Yale. I have had these kids come in, 15, 16, and they've got 3 or 4 publications already. These are usually not black kids. And you say, how did you get this access? It's amazing. And they're talking about the research with such vigor, like they actually get it. They understand what they're doing. So we can start early with these other underserved communities. Medical school, neurology, neurosurgery, neuroscience mentors, the sign group. We have to be active with these groups. Fellowship training, mentoring. And when you get those junior faculty members in, you want to rope them in, get them a sponsor, get them that mentoring that they really need. And this is something I'm very proud of. We started at New York Medical College, which is the Diversity Research Study Group, where we've been training our medical students to be engaged in research related to disparities, health equity, and also working on the pipeline. So we've got college students from Columbia, other undergrads involved. And probably what I'm most proud of is the guy standing right next to the banner, Ralph Osias. He was a high school kid. And what did he do? He did research. He presented at the New York State Neurological Society annual meeting, first student ever to do that. And imagine how big his chest felt and how confident he felt after he came out of that. And when he started his talk, he said, my name is Ralph Osias, and I'm gonna be a neurologist. And that's what we want. We want to start instilling that into our future. Lots of groups to try to support this effort. One of the newer ones is Black Men in White Coats. We just had a big event a couple weeks ago in White Plains where we have black doctors, and you don't have to be black to come there. We want anybody. Come there so these young kids can actually see people who care about them. Regardless of your background, just by you being there and showing your presence tells them, I matter, you care about me, and I can do this. Because if you didn't think they could do it, why would you even waste your time to come to that session? So very, very important when you see these opportunities. And the AES has our own programs that support this efforts as well. And I'm gonna close by just finishing off with microaffirmations. And microaffirmations, I know you probably have all heard about microaggressions a lot, how horrible they are, they make people feel low, they make people feel terrible. But I wanna talk about microaffirmations, because I like to focus on human flourishing. How do we make ourselves be our best selves and our colleagues be their best? These are apparently small acts which are often ephemeral, hard to see events, public and private, unconscious, but effective. And here are some examples in case you didn't understand that definition. They opening doors of opportunity to people, reaching out to that black kid, that Hispanic kid, or whoever it is, that underprivileged kid for whatever reason, and giving them some opportunities that they otherwise would not have. When you have that new faculty member, you say, oh, we just got a black faculty member, great, we're done. It's not just recruiting them into the department. How do you make them feel that feeling of belonging and really feeling included? Listen to them. Having everybody, when you're in a meeting, there's like 8 people, it's not enough to just have the 2 people talking the whole time. You want everybody to be speaking and feeling like they're a part of the group. Give credit, give feedback. And I think that's it. Thank you very much. So the take-home messages, so the impact on clinical care, I have to have that as the last slide. It helps our departments to gain trust of the community for enhanced partnerships. Having more diverse workforce will reduce the racial ethnic disparities in epilepsy treatment outcomes and will contribute to decreasing the epilepsy treatment gap, particularly epilepsy surgery treatment gap. Thank you very much for having me.
Dr. Etienne. Thank you, Dr. Etienne. We'll have a group discussion at the end of it, a panel discussion, so please hold your questions. Our next speaker is Dr. Sharice Sanker. She's from NIH, NINDS, and she'll talk about NIH views of healthcare disparities. And I'm really excited how much NINDS has committed to addressing this issue, so I'm really looking forward to her talk.
Okay, am I on? Can you hear me? Oh yeah, you can hear me. All right, thank you. Thank you so much. That's a tough act to follow. That was a wonderful presentation. And so I'm just gonna give you a little bit, I have nothing to disclose, give you a little bit of an overview of our NINDS Health Equity Strategic Plan that was recently completed, and then talk broadly about some focus areas within health equity research in neuroscience, and then as a group, we can kind of think maybe during the discussion about how we apply these broad equity-related initiatives to epilepsy. And Dr. Etienne already started to talk about some of these principles, so you'll see them also in my slide. So at NINDS, we're committed to reducing the disproportionate impact of neurological disease borne by underserved groups of society by funding a spectrum of research from basic science through clinical studies and training the next generation of health disparities investigators. I'm in the Office of Global Health and Health Disparities at NINDS, and we lead the coordination, development, and reporting on programs and initiatives related to national and international research on disparities and inequities in neurological disease. And we're really here at the AES to really emphasize our need and our interest in increasing research and funding in neurological health disparities, specifically epilepsy. So in August of this year, our NINDS director, Dr. Walter Koroshetz, announced the Neurological Health Equity Strategic Plan, which was really in the form of 10 manuscripts that were published in the journal Neurology. And in this quote, he said, "The national conscience has opened to a new appreciation for the need for action to promote health equity and end the web of conditions that have perpetuated unhealthy disparities." So we've covered a number of recommendations, like social determinants of health, again mentioned, community-engaged research approaches, neuroscience workforce diversity, as well as DEIA efforts and training. So this just gives a really brief overview of the contents of the neurology supplement. If you're interested, you should check out the executive summary. That will give you a broad overview of what's included in those 10 manuscripts. I'll give a few examples from some of the manuscripts so that you can just get a flavor of what's there and what's relevant to epilepsy in particular. So in the manuscript entitled "Lives Lost to Inequities," the authors performed a mortality calculation where they looked at mortality rates in racial and ethnic populations across selected neurologic conditions. And they found with epilepsy, for example, that the highest rates were in non-Hispanic Blacks, followed by non-Hispanic American Indian and Alaskan Natives, and non-Hispanic Whites, and then Hispanics of any race, and in the lowest rates, non-Hispanic, Asian, and Pacific Islanders. This is interesting because, traditionally the referent group has been white, and it's not necessarily the case that it's always the lowest in terms of mortality rates. And so this is a perfect example of intersectionality where we need to be thinking, it's not just about race, but also those other pieces, as Dr. Etienne talked about, under the coin, right, that contribute to disadvantage. There was another manuscript that captured the insights from the request for information that NINDS put out for the Health Equity Strategic Plan, where stakeholders were asked to identify their neurologic diseases that they considered having the most health disparities. And epilepsy and seizure were among the top 5 neurologic disorders. And you can see on the right side the vulnerable populations, including low socioeconomic status, racial, ethnic minority, and the list kind of goes on from there. And when thinking about the domains of influence, so this is, again, getting at those social determinants of health, we understand that there are healthcare services and quality of care, individual level social determinants of health, including patient agency and residential disadvantage, but also this perceived provider discrimination, racism, bias, and health disparity competency. Oops, sorry. I don't think I need that, so I'll leave it there for now. So the one example, this is a quote pulled from the article when giving direct quotes from the stakeholders. One person quoted, "I have also gone with a Black friend to her neurologist appointment to speak as her advocate if needed, because I know I'm listened to more as a white woman." And in another manuscript, we presented the NINDS Social Determinants of Health Framework for addressing health inequities. And this would look familiar to you. This is modeled really from the WHO's work, as well as work from Dr. David Williams. And the MHD, the Minority Health and Health Disparities, also has a socioecologic framework for health disparities. So this is really looking at it from the neurologic health and well-being and the different factors and determinants across, to really underscore that it's not enough to just evaluate biological conditions and predisposing conditions when you're trying to address health inequities. You have to look upstream and think about all of the factors that are playing a role there. So when we're thinking in our office about the tools to advance health equity and taking the recommendations that we received from the strategic plan, 3 overarching areas of increasing diversity and inclusion in clinical studies, increasing health equity research, and community engagement are 3 of the main drivers of how we intend to implement the strategic plan and advance health equity. And when we talk about community, there are many ways to define community, and I've given some examples here. It may be at the level of community organizations and membership, also patients, caregivers, and study participants. It could also be persons with lived experience, either of that disease and or from a population that experiences health disparities, as well as other stakeholders. And when we talk about engagement, we're not just talking about outreach and recruitment, but also how do you sustain that engagement after the intervention is done? How do you build trust and collaborations and incorporate inclusive research from study design through implementation? And sorry, this is a lot on this slide, but some other areas that we're focused on are multi-level studies and interventions, again, utilizing these broad socioecological frameworks, and culturally responsive and inclusive research that really looks at the cultural adaptations of studies and interventions and meets people where they are. Finally, in the recommendations we received, we also saw a lot of calls for diverse and collaborative research teams so that you can incorporate cultural competency, sensitivity, and humility training, and also have the expertise not just in the neurological disorders, but also in health equity in the populations that are experiencing health disparities and in community-based participatory research or other forms of community-engaged research. And I just included this diagram here from Shaflarsky, in 2014 because it's a model of a socioecological framework for epilepsy that you can see kind of maps onto some of the work that the NINDS SDOH framework also covers. Okay, so in my last few slides, I'm gonna give the pitch. So we're really excited this year to launch the Community Engaged Health Equity Research and Neuroscience Initiative. So this is really one of our first major steps in implementing the Health Equity Strategic Plan. And this is in the form of 2 R mechanisms, the R01 and R34. And the goal is to really understand specific drivers of health disparities and barriers to neurologic health equity, and develop sustainable interventions to decrease disparities in neurological health among disadvantaged groups. So for NIH, we have a number of designated populations that experience health disparities, and you'll see that many of these actually fall under the coin, as Dr. Etienne talked about. I like that term, and I'll be using that now. People living with disabilities was recently added this year to this group, and so again, we're thinking about this in terms of intersectionality. Usually one of these groups, you could see how having one or more, belonging to one or more of these groups can increase the disparities that one may experience. So the HERN is the shorthand name for this initiative. The R34 is a planning study for 2 years. It's, you can look it up as RFA NS 24007. And it really is focused on increasing community engagement in populations that experience health disparities, engaging in neurological health equity research, and developing these multidisciplinary research teams so that you can plan for readiness for a future clinical study or trial. And the R01 is a clinical trial readiness R01, so these are not clinical trial allowed at this stage, which is really to set the stage to ensure appropriate recruitment and retention of these populations, ensure that modifiable factors are actually being measured appropriately, and setting up a community-driven study design before the onset of an intervention in order to increase the likelihood of success. And just some examples of some objectives that would be covered under the R34 and the R01 are examining the role of stigma, bias, and or discrimination at multiple levels, identifying specific and modifiable social determinants of health, and then in terms of utilizing SDOH-informed instruments, those will be used to assess and measure different social determinants of health, which can be challenging depending on the types of social determinants of health you're examining, and that's something that we need to do a better job of. So the one thing that we've incorporated in the requirements for these RFAs is the need for what we're calling the CERI plan. It's a community engagement and research inclusion plan. And the goal here is to really ensure that the applicants are thinking strategically about how they intend to engage the communities and address barriers and facilitators of research participation along with the community, develop respectful, equitable, and bidirectional knowledge transfer. And there are these 5 components that you see here that have to be addressed in the CERI plan. That's part of the application. And we held a pre-application technical assistance webinar, so that the second deadline is going to be February 2nd of this next year. So there's still time to apply. If you're interested, definitely come and see me or talk with me, and you can also check out the webinar and contact us at any time. That was quick, so I saved us some time here. So this is my impact on clinical care slide, which is just a summary of what I've talked about in colorful form. And with that, I'd like to thank you for your time and attention.
Thank you, Dr. Sankar. Thank you so much. We're really appreciative of NINDS taking note of this challenge, and I know that NINDS and the federal government can do an immense amount to impact this. So we'll have a panel discussion later and look forward to hearing from you. Our next speaker is Dr. Gabriela Tentilo Sepulveda. She's an assistant professor at Baylor College of Medicine in Division of Epilepsy. Welcome.
All right, hello everyone, good morning. Thank you for being here today. So I'm going to be talking about status epilepticus incidence, outcomes, and mortality. I have no disclosures relevant to the study. And this project was supported by the Center of Excellence for Health Equity Training and Research at the Baylor College of Medicine. So our learning objectives today are to review trends in status epilepticus hospitalizations over time from 2010 to 2019, and discuss factors associated with specific interventions that can be seen of status epilepticus, specifically intubation, tracheostomy, gastrostomy, EEG monitoring, and mortality, and suggest areas of focus for further study and improvement. So as we all know, status epilepticus is associated with high rates of morbidity and mortality, and disparities have been described in epilepsy care in numerous papers, but how they contribute to status epilepticus and their outcomes is an understudied area. So our aim was to examine the relationships between social determinants of health and status epilepticus outcomes and how these change over time. So we use the nationwide inpatient samples. So if you're not familiar with this, this is a database from the Healthcare Cost and Utilization Project, and it covers about 20% of US hospitalizations. So it is a nationally representative database. It has data from 48 US states. And hospitalizations with status epilepticus were identified using billing codes, using both ICD-9 and ICD-10. Status epilepticus prevalence was calculated and stratified by demographics. Joint point regression was used to analyze rates of SE hospitalizations, and survey logistic regression was used to assess factors associated with intubation, tracheostomy, gastrostomy, EEG monitoring, and mortality. So this study identified almost 500,000 hospitalizations over 10 years. And here I'll show the baseline characteristics. So starting with gender, we found that males had a slightly higher prevalence of status epilepticus per 10,000 hospitalizations. In terms of the age, this is more common in the older population, so 60 years and above. Race, ethnicity, so I'll point to the overall population here, which is 64% white, and the status epilepticus population, 55% white, followed by non-Hispanic Black at 24%, although the general proportion was 14.3%. And then Hispanic was about 10%, and then non-Hispanic other, which includes Asian, Pacific Islander, and others, was at 5.8%. We did notice a significantly higher prevalence of status epilepticus per 10,000 hospitalizations. For minority groups, the biggest proportion was in the non-Hispanic Black population, followed by non-Hispanic other and Hispanic. In terms of income, status epilepticus hospitalizations were much higher in the lowest income quartile per zip code, so 34.6%, with a prevalence being higher with the lowest income quartile, and successively reduced as income rose. And in terms of the hospital, the vast majority of these patients are treated at urban teaching hospitals, with 71.3% of status epilepticus hospitalizations and a higher prevalence as well. This is a joint point regression looking at rates per 10,000 hospitalizations going from 2010 to 2019. The overall is the blue with the dots. It's a little bit obscured by Hispanic and non-Hispanic others, but it's important to note that hospitalizations for status have gone up over time. For all groups, we could see there's a big gap between non-Hispanic Black compared to everybody else, and this has actually widened over time. So in addition to the prevalence and incidence, we also wanted to look at interventions associated with status. So specifically, intubation, tracheostomy, gastrostomy, EEG monitoring, and death. And I'll go through kind of the highlights of what we found. So rising age was associated with all of these findings, very much in a dose-dependent manner. With the older the age, the more likely the odds of all of these factors, intubation, tracheostomy, gastrostomy, and death, not necessarily EEG monitoring. And minority populations, specifically non-Hispanic Blacks, but Hispanics and non-Hispanic others as well, had higher odds of tracheostomy and gastrostomy, as well as EEG monitoring in non-Hispanic others and non-Hispanic Blacks. But we'll get to that in another slide. In terms of EEG, there was a significant association with income. So the highest income quartile was almost 50% more likely to receive EEG monitoring comparing to the lowest income quartile. And a significant finding was the association between hospital type and the odds of EEG monitoring. So hospitalizations in urban teaching hospitals had nearly 13 times the odds of receiving EEG compared to rural hospitals. I'll also note that all interventions were more common in urban teaching hospitals, including intubation, trach, and gastrostomy. In terms of mortality, this study found actually highest mortality in the non-Hispanic white population. Minority groups, particularly non-Hispanic Black and Hispanics, actually had a reduced mortality. We found that income was associated with reduced mortality, the highest income quartile, and that self-pay insurance was associated with a higher odds of death. So in terms of putting it all together, disparities exist in status epilepticus prevalence, tracheostomy and gastrostomy with regards to older age, minority, race, ethnicity, and income. Older adults and those of lower socioeconomic status have higher odds of status epilepticus mortality. Access to EEG monitoring is modulated by income and access to an urban teaching hospital. And the vulnerable populations are older adults, racial and ethnic minorities, and those of lower income or rural location. These are vulnerable populations meriting increased attention in order to improve health outcomes and reduce health disparities, and are communities that require selective investment, which may require increasing personnel, resources, health education, mentorship, a more diverse workforce, et cetera. And urban teaching hospitals play a very important role as they treat the vast majority of these patients. So I want to thank all my collaborators at Baylor College of Medicine, as well as Mount Sinai and the University of Virginia. Thank you so much for your time, and I'm looking forward to the panel discussion.
Thank you, Dr. Tantillo. Our next speaker is Joe Sirwin, who's known to many of you. He's now at Mayo Clinic, Jacksonville, Florida.
Thank you, Dr. Kapoor, for the invitation, and good morning, everyone. So I'm going to be covering the topic of looking at the health disparities in epilepsy as it pertains to Hispanic or Latino populations. Here are my disclosures. I do not believe they are pertinent to this talk, but shows you what I am up to, and also serve as AAN editor, Brain and Life in Espanol, and also time commitment with NPR for a weekly medical show. Here are the learning objectives for this particular talk, which is I want to kind of point out that when we talk about Latinos and Hispanics in the United States, it is very heterogeneous. There is so much difference, and we have to understand that when looking at this as a group. We'll look at some of the current disparities as it comes to epilepsy and seizures. And similar to our other speakers, instead of just looking at the problem, try to find the solutions to the problem so that we're not always mired in the same woe is us. You heard beautiful descriptions of social determinants of health. I put this out just as a reminder that health disparities flow from this. But as mentioned already, when the average anybody clinician sees a patient, they're often like, where do you go with this? I love the way that this strikes like from the Hawaiian state of Hawaii's public health. They look at social determinants of health as the upstream, the root causes up there in the mountains. We practice medicine, the clinician down there in the downstream effects, the chronic disease burden. But we can still impact those upstream measures. And there are ways of doing it, both as a combination of policy as well as other things that can be done even at very local levels. Well, here's the facts when it comes to Hispanics in the US. It is literally one of the fastest growing minority populations in the United States. This is data from the 2020 US Census. And as you look at that, Hispanics are projected to make up nearly 30% of the national population of the US by 2060. It is a huge group, and it just shows you how that percentage continues to grow at this time. Where are they? Well, you're in one of the locations that you'll see lots of Hispanics. Florida is one of the ground zeros for Hispanic populations. But if you look at these maps, they kind of splay out for you based on the 2020 census where we are all living. Number one, it's all over the country. That's lesson one. But number two, there are certain locations, certainly in the Southeast, and then look what happens as you go from Texas all the way to California, where it's the deeper, darker colors there. That's where you see the numbers. But it's not just that area, and people forget that. Look in the middle of the country, look in the Northeast. Look the fact that nothing is exactly perfect white on that map. It is always a little shade of yellow, showing that it's sprinkled throughout the country. And it just shows you what percentage. It kind of estimated now at 19.5% and growing, depending on where you get the numbers. What makes us similar to one another? So what are the things that binds the U.S. Hispanic population? There is not one thing, but there are a few things that do seem to strike at least a chord in terms of identity. Interestingly enough, speaking Spanish or connecting via the language is a big deal. And that actually shows up whether you're in the foreign-born Hispanic U.S. person versus the third or higher generation in that regard. Having parents of Hispanic heritage or descent, it's a story of immigration. And then look how it plays out, socializing with other Hispanics, a Hispanic last name, participating in cultural celebrations to faith or attire or things of that sort. But the point is, it's heterogeneous. It cannot be looked at as one point. As brought up earlier beautifully, we have to have cultural humility, understand that you're not just talking to one person, but this gives you a sense of where we're going and what it looks like. As I say, big point, it's a heterogeneous group, as noted by all the flags and the people and the look of the people and all the things. So it crosses ethnicities and races, and it's not just one group. Let's get to the epilepsy part. You've seen some of this data already, but I will point it out. We know that 382,000 Hispanic patients with active epilepsy have self-reported epilepsy, or 0.9%. 168,000 have inactive self-reported epilepsy. And this is all based on the National Health Interview Survey from 2021, so somewhat recent. We did a study based on Arizona Medicaid. We had exclusive rights, just by luck, to the Medicaid database of the entire state of Arizona, which tracks everyone that is in that group. So it's going to be a more poorer group, but it would collect and give you a sense of where things are going. And one of the things we wanted to find out, based on Arizona, because that's all we had, is that do epilepsy patients, does it turn into a ghetto? Do they live in certain zip codes, areas? And the truth was, the answer is no. Basically, if you were in Medicaid, it didn't matter where you lived. It's just had to be where the finances dictated that location, as opposed to you're going to find this number of people in one particular location. So we did not find that. But zip code does determine a lot of other disparities, as already brought out. So what do we know about the disparities within epilepsy? Well, we know that it does seem to impact the non-white individuals, that the rate of epilepsy was 1.3 to 2 times greater for non-whites compared to white males. You heard that earlier. We know that the age-adjusted prevalence of epilepsy for African Americans, we heard that. And then elderly Hispanic men had prevalence rates of 15 to 18 per thousand compared to non-Hispanic men of similar age group. In a recent study looking at genetic epilepsies, is there a disparity? And one of the things that they found is that they could not find differences between Hispanics in the EPGP group versus other groups in the rate of generalized epilepsy, always a good news there, and no difference between the attitudes and beliefs about genetics with epilepsy and Hispanics in that grouping as well. What do Hispanics know about epilepsy? So this brings us to a study that I did, and this is embarrassing because I thought this would have update when I was looking to do research for this. This was published in 2005. As I look for more recent studies, there aren't any. So this still stands almost 20 years later is what we know. And this was based on a national telephone survey in 760 Spanish-speaking areas in 7 of the largest U.S. Hispanic metro areas. This was funded by Epilepsy Foundation and also done with the folks at the RAND Corporation to figure this out and to see what do we know and what do they know. So this gives you a glimpse. We knew that Hispanic respondents were younger with lower income and education levels than non-Hispanic respondents based on that. So that gives you a sense of where some of the information's coming from. We also saw that many Hispanics in the U.S. are unaware of epilepsy. They've never heard of it or had misperceptions regarding epilepsy. We saw that there was concerns about the language, and I find this always difficult no matter where you go, is that the word for seizure isn't always translate easily. So you're under the words of ataque or convulsiones, but that also can convey other areas in neurology as well. So the language even gets confusing as to how this plays out. We also saw that, and sadly, seizures this is a perception, were often still considered as associated as contagious illnesses or bad behavior or overdoses were some of the words that were used when it came to this. 20% of Hispanic respondents thought patients with generalized convulsions were drunk or on drugs. And that was one of the sad realities. And again, we don't know how it's changed in almost 20 years, but that's where we started in 2005. These were also some of the other misperceptions of epilepsy that led to some of the stigma within the community. I'll point out, these are all the ones with asterisks, and you'll see that those are all significant. But there was sadness about the fact that you need total supervision. The family is going to hide the condition. The unlikely to get married or hold a steady job. A lot of things that just is, kind of holds people back within that stigma, if you will, which is a huge area for this. And then it came to the other parts. It's dangerous to others, or they die at a younger age. So these were things that just kind of stood out from the Latino community from that work. Many Hispanics in the U.S. attributed epilepsy to common preventable causes. And that's especially when you look at this, either from lack of oxygen to injury to the head as an infant or meningitis. So there's some positives in that. They got some aspects correct, but we still have work to do, at least as put out from that direction. One of the things was that being in close proximity to someone with epilepsy could lead to epilepsy, again, highlighting that contagious piece, which we very much want to destigmatize and eliminate. The good news is that there was an emphasis on taking care of your mind and body as a treatment for epilepsy, which is the right answer for any condition, to be honest. So anything from taking medicine to exercise to vitamins, and luckily things at the very end were tiny fractions, spiritual healers or exorcism. Not that we have any problems with spiritual healing or anything along those lines, but the point is they did not take up the top portion of that perception. One of the many Hispanics were also willing to get involved to help someone else experiencing a seizure. So that was a very positive element in terms of just saying hopeful answers and potential for solutions. Improving knowledge and perception of Spanish-speaking adults is really key, and that may mean printing things, and almost every organization has things in Spanish, or approaching them certainly from the area of their culture, whether that's audiovisual material or showing that the pictures that the people see look Hispanic or Latino into some direction so that it looks applicable to everyone else. And I think that's important, especially with the internet and social media. Those can be wonderful kind of solutions. There was good news, as I promise I want to take us towards solutions. The good news is that the Hispanic culture, if you will, that surrounds us can be protective and actually beneficial in the management of seizures. Hispanics were actually lower in depressive symptoms in patients with epilepsy based on a few studies because they had a higher rate in self-efficacy. They were unlikely to have depression based on a couple of very brief studies that we've looked at certain one-center evaluations. And this was especially true if their primary language was in Spanish and they were being spoken to within that language. So that was one of the elements, just approaching them where they live, how they talk, seemed to be a big issue. The challenges that we find on the other side is that Hispanic patients, you heard this a little bit ago, they're less likely to undergo surgical treatment. They're more likely to be treated in the ED as opposed to seeing an outpatient neurologist. So they touch the health system in ways that aren't really in the neurology sector, but more in the ER sector and more in the hospital. Interesting enough, they're less likely to receive anti-epileptic drugs, which is a huge issue, and less likely to receive specialized care compared to white patients. So that's what we know. In our Arizona study, when we published this on the Arizona Medicaid, one of the striking findings that we saw, and this was particularly true for Native Americans and Hispanics, that about 43% of that study population, they had a median delay of filling the prescription, because the insurance told you when you actually picked up the pills, of 180 and 73 days respectively after a diagnosis was made. So you get the diagnosis and it takes somewhere close to 3 months before you even start the medication. And that was like, well, how is that possible? And this is with Medicaid insurance, a safety net. In other areas, we found that Hispanic kids in Salt Lake City, in another study published, had a decreased likelihood of achieving seizure control and remission. So how do we bridge this? This is one, as you heard before, social, structural elements that can really help to improve things. Healthcare providers, and this is what was found in some of the studies from the Latino groups, is that healthcare providers are often viewed as dominating as opposed to coming to you within an equal relationship. That shared decision-making doesn't seem to be at play for some reason. The relationship with the healthcare provider, whoever that is, pharmacist, nurse practitioner, PA, doctor, it matters. It matters big, because if they don't like them, they don't follow the advice. Speaking in Spanish matters to those that's the main language, and then the valid educational materials in Spanish is key. You have to know the values of the Hispanic cultures, that family dominates, faith is important, naturally optimistic, social acceptance is important, and integrity and respect are essential. I love this. This gets us to kind of areas of solution. What can you do in a clinic to really make the difference? And this is splaying out different social determinants of health, and how do you move forward in terms of certain groups and what do they need. To the Hispanic patients, access, so that's a policy solution, but notice that communication, social support, education, those are the biggest elements. More time to kind of have a relationship. And I know, as someone who was a former chair of a department, that's like the last thing anyone wants to hear. But the reality is that is how you get anywhere when it comes to this. So the impact on clinical care is the following. The cultural barriers seem to be the biggest disparity in U.S. Hispanics with epilepsy. That barrier leads to treatment gaps. And the way we have to adjust and change this is our appointment duration with these individuals. Relationship building, which takes time, takes us back to the older days of medicine. And that we have to bridge the cultural element with that humility. Those are the solutions to manage those epilepsy disparities. So easy to say, so hard to put in practice, but the solutions are there. So with that, I appreciate your attention, and thanks so much for listening this morning.
Thank you, Joe. And our next speaker is someone who's actually in the trenches. Karen Shea is the founder of El Paso Center for Seizures and Epilepsy, which she serves as the only pediatric epileptologist in a 250-mile radius. Welcome.
Thank you very much. All right, so this is going to be a little bit different of a talk. It's less of kind of an overview, although I do some of that, and a lot of it is just my kind of personal experience providing care in El Paso. I don't have any disclosures. My learning objectives, so I want to discuss limited English proficiency as an under-recognized barrier to health equity, recognize factors that lead to physician shortages, because this is something that's at play in a large part of the United States, and then list individual and systemic ways to fight health disparities. So some of you may look at me and be like, why is she in El Paso? I am not from Texas. I actually wasn't going to be a doctor. I was a neuroscience researcher when I was in college. Decided that that wasn't where I wanted to spend my life. I spent 2 years in the Peace Corps in the Dominican Republic. And I saw there the impact that a lack of access to healthcare had on the community where I lived. And then I got caught up in academic medicine for a while. And actually, I was working as an associate professor in Austin, and we were getting patients from El Paso. And my Texas geography wasn't great, but I knew that El Paso was like way, way over there. And why were these patients showing up in El Paso? So the El Paso County population is about 870,000 people. There's about 225,000 children. I'm a pediatric epileptologist, I should have said that. So estimates about 1,300 children with epilepsy in El Paso, and there were no pediatric epileptologists. I couldn't believe this. So I decided that's where I needed to be. So I interviewed with the Texas Tech School of Medicine, which is in El Paso. It's the only one there. And they offered me a job, but they wanted me to give up my specialty and be a general pediatric neurologist, which is not who I was. So I ended up leaving academia and starting a private practice clinic, which was quite an experience. So in terms of providing care in El Paso, there are certain defining characteristics that are important to take into consideration. One, it's part of Texas, it's isolated geographically, there's a high poverty rate, and it's a border city. So just starting with the last one, for those of you who are not familiar with El Paso, it is pretty much one city with Juarez, with kind of the border going right in between it. That picture there is people coming through the border, and you can see El Paso there in the background. As a result of being a border city, it's got a very high percentage of Hispanic ethnicity, and I call it Hispanic because that's what most people there use. More than 2/3 of people speak Spanish at home, and more than 1/3 of people have limited English proficiency, which I was recently told is not the PC term, but I'm not sure what the PC term is, so I'm just going to use that. I want to talk briefly about limited English proficiency. So this is a graph that shows the explosive growth of immigrants in the United States. And I'll say this data kind of caps at 2022. So this was before all the crazy influx of immigrants over the past year or so. So what you can see is that the immigrant population has increased in the orange from 4.7% of the US population to 14.6%. So 14.6% of the US are immigrants. And if you look just at the numbers, it increases from 9.6 in 1970 to whopping 47.9 million immigrants in the United States right now. So 56% of these, over half, have limited English proficiency. That's 27 million people, or about 8% of the US population. So 1 in 12 people in the US have limited English proficiency. And if you look just at Spanish speakers, there's 17 million monolingual Spanish speakers, so limited English proficiency, they're Spanish speakers, which is about 5% of the US population, or 1 in 20. So I found this article from the AMA Journal of Ethics talking about should all US physicians speak Spanish. And the interesting thing about this is that it was published in 2008. And since then, the LEP population has grown another 13%. So even back then, they recognized that this was an issue. So the complicated part is that only 2% of non-Hispanic doctors actually speak Spanish. And so what you end up with is a lot of this. And I will say this is not the way you're supposed to use interpreters. It should be the doctor and the patient having the conversation with the interpreter at the side, but we know that a lot of times this is how it ends up. And so how does limited English proficiency impact epilepsy care and outcomes? So some of these are a little bit different than the studies that Dr. Servin used, but they are on significantly fewer anti-seizure medications, despite the fact that there were no differences in epilepsy-related factors. This study showed they had higher rates of depression, but were less likely to be on antidepressants. Limited English proficiency was an independent predictor of not undergoing epilepsy surgery, even though Hispanic ethnicity was not. And there were longer wait times between the pre-surgical evaluation and the actual surgery in patients with limited English proficiency. And so this slide is slightly outdated, but these are the NIH-designated US health disparity populations. At the top, racial and ethnic minorities, socioeconomically disadvantaged populations. There should be people with disabilities on there as well, that is not where it's supposed to be. But one of the things that was really surprising to me is that people with limited English proficiency were not considered to be one of the high-risk populations for disparities. So this is a hopefully soon to be published study that I worked on with the Pediatric Epilepsy Research Consortium, SIG, on health equity. And so this is looking at, we just basically went through all publications having to do with pediatric epilepsy. And we looked how often those outcomes were evaluated by certain disparity factors. And so you can see there sex, not surprisingly, was the most commonly explored, followed by race, ethnicity, socioeconomic status, and then down at the far right is language and immigration. So that was the least explored topic among all of these papers. But then when you looked at the percentage of these publications that actually showed disparities, it was very high in terms of language and immigration. So they showed the highest rate of disparities. So now that I've said that, I'll tell you that limited English proficiency is not actually a problem in El Paso. And that's because it is not a very ethnically diverse area in and of itself. As I mentioned, it's 83% Hispanic. And I speak Spanish fluently. My nurse practitioners speak Spanish fluently. Most of my staff are fluent in Spanish. So actually, in the 18 months the clinic has been open, I've only used an interpreter, which is actually Google Translate, twice. So the question is, what makes providing care in El Paso so difficult? So I like to draw comparisons between El Paso and Louisville, Kentucky. I had my first position out of fellowship in Louisville, and they have some similarities. They're both kind of mid-size cities in the US. But if you look at the number of pediatric neurologists between the two locations, there are 31 in Louisville, Kentucky. This is doctors and nurse practitioners. And there is one pediatric neurologist in El Paso. And as far as pediatric epilepsy goes, before I got there, there weren't any. Now there's me and my nurse practitioner. I'm looking to hire another one if you know of anybody who's interested. So what is causing this physician shortage in El Paso? So this gets back to kind of the characteristics of El Paso. So number one, it's part of Texas. And you guys have heard the phrase, everything's bigger in Texas. That includes the uninsured population. So if you'll notice on that diagram, Texas is its own category. It's the only state that has this incredibly high risk or incredibly high rate of being uninsured. And part of this is because Texas refused to expand Medicaid. So for those of you who don't know, Medicaid expansion is basically an effort to extend Medicaid to a larger number of people. The state only has to bear 10% of the cost, and then 90% of the cost comes from the federal government. But Medicaid expansion was rejected by the Texas governor, Greg Abbott, because he built his career off of opposing the Affordable Care Act. And as a result of this, Texas is turning down $5 billion in federal funds every year that could be spreading to take care of some of these uninsured patients. Despite this, Texas Medicaid is actually one of the most restrictive. So parents in a family of 3 are denied coverage if they earn more than $4,000 a year. And if you look at the per capita Medicaid expenditure, again looking between Kentucky and Texas now, Texas spends $1,433 per Medicaid participant versus Kentucky, which spends $2,390, so a huge difference. And if you look at the actual reimbursement rates, this pans out. So in Texas, for a new patient visit, you get $112. In Kentucky, you get $143. And that same trend is seen for the follow-up visits. And for those of you who complain about Medicare, I'm just going to point out there that Medicare pays twice as much as Texas Medicaid. So why is Medicaid such an issue in El Paso? Well, it's because it's an area of very limited local resources in terms of income. You don't notice it so much when you compare Louisville to El Paso in terms of the median household income, but if you look at it per capita, you'll see that there's a huge difference. So many of the people in El Paso have multiple people living in the home, and so that money does not go nearly as far. And as a result of these limited local resources, El Paso was very late to get a medical school. It was late to get an El Paso or a children's hospital, and those are the things that really attract physicians, especially specialty physicians, and so they've been hard to attract. Then if you look at the payer mix, this has a lot to do with it as well. If you look at insured children in El Paso, 62% are Medicaid versus 40% which have commercial insurance. And again, Texas Medicaid only pays $112 per new patient visit. Looking at Austin, which is where I was before I came to El Paso, it's kind of flip-flopped, where 60% of patients have commercial insurance and 40% have Medicaid. And commercial insurance pays up to or even more than $250 a new patient visit. So as a result, Austin doctors and hospital facilities, et cetera, make 20% more per average seeing a patient in Austin than you would get seeing a patient in El Paso. And I don't know how many of you are in private practice. I'm guessing not too many, but that's a huge difference, 20%. And so how does that play out? Well, in Austin, last time I checked, there were 46 pediatric neurologists. That includes doctors and nurse practitioners. And that's a ratio of 1 provider per 5,700 kids. And as I said, in El Paso, there's 1. So that's 1 per 252,000 kids, which is amazing. And I'm not gonna mention any names here, but there is a large Texas pediatric hospital that is opening a new children's hospital and many new clinics. And can you guess where they're doing it? In Austin, because that's where they can make money. So another factor is geographic isolation. So I'm sure most people don't realize, but El Paso is actually the same distance from San Diego as it is from Houston. And that means that it's very hard. El Paso, isn't part of the rest of Texas. It isn't part of San Antonio, Austin, Houston, Dallas. And if you look at the map, there's not a lot of big cities around. Well, there's none. No big cities around El Paso. And so I think this really affects kind of the attractiveness of El Paso to a lot of physicians. There's no hub at the airport. It's hard to get in or out. And then these things also affect our patients. So El Paso, despite having a greater population than Albuquerque or Tucson, does not have a level 4 NAEC accredited epilepsy surgery program, peds or adult. And the closest ones are in Albuquerque and Tucson, which are about 4 to 4.5 hours away. But Texas Medicaid won't pay for that because they want to keep Texas money in Texas. And so my patients are having to travel 8 to 11 hours to get to some of these centers on the eastern side of Texas. Nobody comes to El Paso unless they have family here. I actually had a parent tell me that just the other day. And so why is that? Again, it's a border city, and I think that there's a lot of fear associated with border cities, in particular Juarez. But I don't know why that's off again. But if you look at the crime rate per 1,000 people, both in terms of violent crimes, property crimes, if you compare El Paso to Austin, Dallas, and San Antonio, El Paso has significantly fewer. And even if you look at El Paso compared to smaller mid-sized cities, it's significantly lower as well. So, and because it's a border city, as I mentioned, there's an awful lot of Hispanics there, 83% of the population. But if you look at the composition of med students currently, it's only 12.1% Hispanic. And if you look at physicians, it's 6.2. And then remember that only 2% of non-Hispanic physicians speak Spanish. And so that means that they're going to be doing a lot of this, which I don't think any of us really enjoy. So providing care in El Paso, this is what it comes down to. I'm on call 24/7. There's no exception. So that's patient calls, patient portal messages, calls from hospitals, calls from emergency departments, calls from pharmacies, calls for insurance. That's all kind of coming to me. Because of the poor payer mix, it's hard to make the clinic profitable. So as of right now, I'm working 2 jobs on the side to be able to keep the clinic afloat, but we have some changes in mind, so I think that's gonna get better. There's no pediatric EMU in El Paso yet, but I'm working on it. And so as a result, we get ambulatory EEGs on the ones that we can, and then the kids that we can't, the little wiggly ones, we have to refer out. I spend hours on the phone with Medicaid, wonderful Texas Medicaid, even for generic medications. I recently got called about prescribing lacosamide, generic lacosamide for a patient, and they said that that patient had to fail 5 different medications on their formulary first, and their formulary included things like phenytoin and vigabatrin. And then there's poor social support for patients. There's no Epilepsy Foundation there, despite it being a relatively large city. And yet, despite that, I think, opening this clinic has been one of the top 3 decisions in my life, followed by Peace Corps and marrying my husband. I would never go back to academic medicine, actually. And part of that is because of the people that I work with. I actually staff the clinic with pre-med students almost entirely, well, with the exception of my nurse practitioner. And part of that is because I want them to learn how broken healthcare is in this country. And they get a lot out of it as well. They're all very happy working there, as you can see by the smiles. And as of right now, we have served 893 patients and families in the El Paso area. So what can you do? So number one is educate yourself about the economics of medicine. When we're in academia, we're like in this little bubble. You know, we see, just like you were saying, we see patients, we bill for them, you know, put in our little codes, and that's about it. But you never see anything beyond that. And I think once you do, at least for me, it really opens your eyes about the impact of some of these structural determinants of health on the care we provide for patients. And it's important to push for medical economics as part of med school curriculum as well. And then ask questions. Are your institution's policies in line with your values? So is care accessible to patients and families at risk? So are there after-hour clinics? Are there longer appointment times? Just like Dr. Servin was saying, when interpreters are utilized, it's effectively half the amount of time to talk with the patient because everything has to be repeated. And then do they have a sliding scale for uninsured patients? And then the other thing is to vote. These are, again, some of the structural contributors to you know, a lot of the disparities we see in health in this country. So expand Medicaid, you know, push for a single payer health system. And the reason I say that is because right now you saw that incredible disparity between what commercial insurance provides and what Medicaid provides. And who's gonna wanna go and get 20% less money in El Paso when they could be making more money in other cities? And then affirmative action to get, you know, Hispanics into the pipeline, as we were saying. So we need more Hispanic doctors. And then finally, consider leaving your comfort zone. So, you know, you can be pediatric neurologist number 50 at a large institution in a big city, or you can be pediatric neurologist number 3 with me in El Paso. And so, you know, think about where you could make a difference. And then with that, I'll just say we are hiring, and that is the view out my window. So thank you very much.
Thank you, Karen. Thank you for this very inspiring talk. And we'll go on to look at another way of bridging the geography, and this time with Dr. Elizabeth Donor, who's the head of Division of Neurology and Director of Comprehensive Epilepsy Program at Hospital of Sick Children in Toronto, and she's also a chaired professor in epilepsy research at University of Toronto. Welcome.
Thank you. And I apologize, I'm losing my voice a little bit, so I just have that as backup. What a tremendous call to action. Thank you. And this has just been a great symposium. I'm so pleased to be part of it. Thank you, Judy. I'm going to talk about something a little bit different. I'm going to talk about how we have been using something called Project ECHO to bridge the geographic divide or geographic inequities in the province of Ontario in Canada, where I live. Don't believe my disclosures are particularly relevant. So our learning objective will really to become familiar with the Project ECHO model as a tool to reduce epilepsy care disparities. So about 10 years ago, my colleague and mentor, Carter Sneed, decided to lobby our provincial government in Ontario, and healthcare is delivered by the province. They oversee healthcare delivery, to improve epilepsy care across the province. And he was actually successful with a lot of lobbying and a lot of support from many of us. And the government decided to increase the number of hospital beds for epilepsy, basically EMU beds. So they basically doubled the number of EMU beds, and they developed a system of comprehensive epilepsy programs. I shouldn't say they. We all developed this system of comprehensive epilepsy programs, of course, with their support. And what you see there is a snapshot of the lower portion of the province of Ontario and the location of both district epilepsy centers and regional epilepsy surgery centers of excellence. The idea being here is there's kind of two types of comprehensive epilepsy centers. There's ones that do kind of everything except surgery, and then there's ones that also do epilepsy surgery. So our two surgical locations are in at least for pediatrics, which is what I work in, are in London and Toronto, London, Ontario, and Toronto. And we also have centers in Ottawa, Kingston, Hamilton, and a center up north in Sudbury. Pardon me. So the challenge here is, how do we get all Ontarians who are spread around a very large province to access care at comprehensive epilepsy programs? I don't know if this works, but I just want to show you, so the comprehensive epilepsy programs are here and kind of down here, and this is the whole province, right? So how are we going to get access to specialist care across this very large, geographically disparate population? And how do we avoid this idea of sequestered knowledge between patients and providers, as well as among providers? Well, the answer for us has been, and hopefully will continue to grow to be, Project ECHO. So for people who don't know what Project ECHO is, Project ECHO was started by Sanjeev Arora, who's a hepatologist in New Mexico. And at a point in time, he was the only hepatologist treating hepatitis C. Well, I don't know much about hepatitis C, but apparently when you can cure hepatitis C with treatment. And there were many, many individuals living with hepatitis C in quite a few apparently in prison, but many people living with hepatitis C who just weren't accessing the treatment because he was kind of the only guy to see. And there were wait times to see him and travel times to see him. So he developed this Project ECHO model, and he actually demonstrated in a randomized trial published in the New England Journal of Medicine that it was effective at treating patients. That he essentially showed that an equal number of patients treated in his specialty clinic at the University of New Mexico and those treated at ECHO sites had the same outcome. And so what exactly is this kind of ECHO thing? ECHO stands for Extending Community Healthcare Outcomes. And what ECHO does is it creates a community of learning by connecting an interprofessional specialist team, which we call the Hub. There's a fair bit of jargon in ECHO. So there's a hub and spoke model. So the hub is made up of specialist providers. So those could be physicians, but you may also have pharmacists, other nurse practitioners, social workers, and other people working in the field. And those specialty teams connect with primary care providers or community-based healthcare providers, which are called the spokes. And the idea here is to move knowledge, not people. So we are essentially training little mini specialists to provide care in their communities so that the people living in those communities can seek care in their community and don't have to travel to big cities to get the care. And Project ECHO is a serious movement, so probably some of you have heard of it before. It has a mission to democratize medical knowledge and get best practice care to underserved people all over the world. 93% of countries in the world have been touched by ECHO. There's over 600 training centers. And if you're going to participate in ECHO, I think it's very worthwhile to get the training. And over 3,000 ECHO programs have been created around the world. So what started in New Mexico with Dr. Arora has actually become a worldwide movement. There's this philosophy of all teach, all learn. And again, I kind of warned you, there's a lot of jargon in ECHO, but some of this actually resonates with me quite strongly. And so it has been true of my experience, and I believe that of my colleagues, that as much as the spokes, the community providers, learn about epilepsy from me, I learn a lot about what it's like to treat epilepsy in the communities where they work and to care for children with all disorders in the communities where they work. Much like the talk that we just received, you know, it's eye-opening, and it's important for me to understand what they are doing so that I can serve their populations. And ECHO, when done properly, will benefit care across the continuum. So patients obviously benefit because they will get the right care near home on time. Providers benefit, hopefully, because we acquire new knowledge on both sides. Ideally, we treat more patients. And there's this idea that the the providers that attend our echo sessions are really building, are joining a community of practice, not just with the experts who make up the hub, but with the other spokes. And so we really like to see a nice relationship building among the community providers. And I know when I speak with my colleagues who, I work at a big academic health sciences center, but when I speak with my colleagues who work even in a big city like Toronto, but in isolation and community practices, I really hear about how isolating it could be with no one to talk to about that kind of difficult patient, interesting patient, whatever. And so this really builds a community where they can, have friends who are facing the same things they are in their practice. For the community, the aim would be to reduce disparities in care and hopefully to retain providers working in smaller communities because they feel supported in delivering care to more complex conditions, and also keep patients local. And what that really means for the system is increased access and improved quality of care, and also cost savings because we're not bringing patients down. Every time a patient comes down to see me from Northern Ontario, they often fly, they stay in a hotel, families miss work, and thankfully our province covers those costs, but it's a cost to the system and it's a personal cost to families. So I've told you kind of about it, but let me tell you how it actually works. So each echo session includes a case-based learning module. And the way it works, and they're all delivered by Zoom, and the focus is on a management of a specific condition. So for example, we run Project Echo Epilepsy Across the Lifespan, and it's focused on training people in epilepsy. But there's very strong, well-established echoes on all sorts of topics, including chronic, in Ontario alone, we have like chronic pain, we have complex care in pediatrics. There's lots of ways to apply this. And each session follows a very specific process. And I've attended echo sessions where we follow the process, and I've attended echo sessions where we don't follow the process. And I actually think the process works, which is why I strongly encourage people to go get their echo training if you're gonna kind of take this on. And so we always start with welcomes, which includes everybody on the call introducing themselves. And that's kind of how we're building that community, right? We're trying to take the impersonal part of Zoom out of it. We encourage people to turn their cameras on, and we encourage everybody to introduce themselves and participate. This has become harder during and after the pandemic because there's such tremendous Zoom fatigue. I'm sure every person in this room is familiar and feels that, but we still try for it. So everybody gets introduced and says kind of where they're from. And then we have a very short didactic presentation. And the goal is not for these sessions to be focused on the didactic presentation, but we do have a curriculum. I'll show you some examples of kind of 10 to 15 minute didactic presentations to just kind of get people thinking about some pearl, for example, about epilepsy. Then we move on to the case, and the case is the meat of the session. And our sessions, we used to do 90-minute sessions, and we came down to 60-minute sessions. So now we move on to the case, and ideally cases are submitted by the community providers, by the spoke members of the community, and they're anonymized cases. And so we have a template. It's meant to be a very easy presentation just for them to share a little bit about the case and state what their questions are with regards to the case. And then we go to clarifying questions. And this is where people start learning. Because first I go to the other community providers and I say, what questions do you have for, Sue about the patient? And they ask the questions, have you tried this med? What did the imaging show? Any of these kind of questions. Then we go to the hub members for questions, and they ask questions that may not have been asked. Then we return to the community members and we say, what are your recommendations for the case? And then we return to the hub members for the final kind of recommendations. So it's really an iterative learning process, and it's that process that builds the little mini specialists and teaches people how to think through the case. It's probably not that different from how you run rounds, right? First you ask the med student, okay, what would you do? And then you kind of go up to the resident and the fellow. But you're doing this with fully trained, pediatricians, family doctors, nurse practitioners working in their community. But it really builds competency. Then we close up. It's not telemedicine, and I've seen echo sessions run more like telemedicine, and doctors will bring cases, they will get answers to their cases, but they will not build their own capacity in how to treat epilepsy. So telemedicine, I see a patient on Zoom and I just see them virtually. Well, my gosh, that's like half our practice now, right, with so much virtual medicine. This is different. In a tele-echo clinic, the hub team supports the community practitioners to develop a plan, and it's all anonymized. So actually, I'm just going to go forward one. So our project ECHO, which is focused on epilepsy across the lifespan, has hub sites across the province. And each hub runs 10 session cycles about every 12 months. And actually, we've recently changed this, so this is a little outdated, and if any of my colleagues are in the audience, they'll know that. But we started out with pediatric and adult-specific curricula, and we've modified that a little bit, and I'll speak to the curricula as it goes. But community members or spokes can join any session. So for example, Sick Kids Where I Am will run at noon on Mondays, and we'll do that for 10 weeks. Anybody can join from any place, but the idea is that hopefully people will people will develop a relationship with me and my hub team, and they will keep coming back to my sessions so that they really feel like a community with me and that they can reach out to me outside of ECHO to discuss patients. And, okay. I wanted to go back a slide, but I don't need to. That's okay. What I'll tell you is our hubs are made up of, ideally, specialists that touch many kind of areas of epilepsy care. So at our hubs across Ontario, we typically have an epileptologist, a pharmacist, a social worker, a nurse practitioner, a psychologist, and like an epilepsy advocate or someone coming from a grassroots organization. I would love to tell you that we have all those people at every hub. It's not been that easy to kind of recruit and always find those people, but that's the gold standard. This is an example of the curricula we started with, and you certainly don't need to read this, but just this idea that we had this epilepsy curriculum and an epilepsy pediatric curriculum and an adult curriculum. And it starts with things like, what are seizures, seizure semiology, how to treat with meds, but we also get into some kind of other topics of interest. We've done cannabidiol. We do a lot on comorbidities. For peds, we talk about transition to adult care. For adults, we talk about pregnancy, teratogenicity, driving rules, all those kind of things. And recently, actually, we revamped our curricula to represent the fact that we have kind of, because we've been at this now for quite a few years, we have people who are new and people who've been with us before. So we have like a basic curriculum and an advanced curriculum. Most people still retake the basic curriculum because I want to remind you, these just represent that 10-minute didactic. The bulk of the time is talking about the case. And the case doesn't need to meet the didactic. So people are happy to hear a short didactic again. The other thing we've done is we've grown our curricula. So we now run an ECHO session for residents and neurology trainees. We run a session on, like a whole series on genetics. We run series on, we recently started one on deep brain stimulation for epilepsy. So we're branching into kind of very specialized area that target very specific types of practitioners, but still maintaining this very general one for pediatricians, general neurologists, and family doctors and nurse practitioners who are spread around the province. When we first started, it looked like the upper left, and the hub team would get together in one room, and it was really fun. And then our spoke members, our community members would be like on the screen in front of us, and we'd talk through the cases, and it was great fun. Then of course we got to COVID now, and everybody moved to Zoom, and now we've never gone back to meeting in person. That's an example of what like our Zoom screen might look like with a few people joining, and we use a purple background to identify those of us that are hub members, and then we, you know, the spoke members, hopefully they turn their cameras on. This was a good day, we had lots of cameras on. So these actually numbers are slightly old, but since 2018, we've had now probably around over 700 unique attendees to our ECHO programs, and the numbers have risen in a kind of exponential way. I mentioned that we have a variety of curricula, and the other thing we offer are immersive experiences or boot camps. So we do in-person learning days right now. We're experimenting with that, where people actually come to a hub center. Our next learning days, we're doing some in Toronto and some in Ottawa, and they can come have a full day of CME learning. We support people's travel to join us. That's also about building the community. Our target is physicians, mainly because we are funded to improve physician knowledge, but you can see we get other types of people joining our sessions. So about 75% are physicians, but we do get nurse practitioners, nurses, we get community advocates, we'll have a pharmacist, a physiotherapist, anybody working in the epilepsy field is welcome to join. After our pediatric after one of our pediatric sessions a couple years ago, we kind of looked at our outcomes and asked our participants how they felt about it. Because we all know what it's like to talk to a Zoom screen, and you really want some feedback to know whether you're really making a difference to how these people practice and how they feel about their competencies. So I was happy to hear that 96% would recommend participation in our ECHO to their colleagues, and 88% agreed or strongly agreed that ECHO was improving the quality and safety of the patient care they were delivering to people with epilepsy. 73% said they had shared what they learned with a colleague. That's a really important part, because the idea here is also, let's say there's a community with I'm in pediatrics, let's say there's a community with 5 pediatricians up north. The idea is if that one of those pediatricians can join my ECHO sessions, that they can be the pediatrician in that community where the other pediatricians refer their kids with epilepsy, right? To like build capacity in one of the individuals in that community, and that way they become the kind of the mini specialist. We also asked about their confidence with regards to certain skills, and statistically significant improvements in differentiating seizure types, in their confidence to perform investigations for the cause of seizures, in their confidence to diagnose epilepsy, and to select the appropriate medication. And they also told us they had significantly more knowledge with regards to prescribing anticonvulsants, determining when a patient is drug refractory, recognizing and managing comorbidities, and serving as a local resource for the community or the clinic regarding epilepsy. So this was obviously very reassuring. So I will leave it at that. I hope I've shown you that Project ECHO is a tool for distance learning that can build capacity in local communities and overcome a treatment gap. Thank you.
Thank you, Elizabeth. And now we have Dr. Camilo Gutierrez from University of Maryland, and he'll talk about the role of education in bridging the disparities.
Thank you. All right, so the idea with this talk is to give you a framework so that you can go to your institution and based on whatever education endeavor you may have, be it teaching the faculty, teaching the residents, teaching the fellows in epilepsy, or just maybe in your institution, that you can develop a curriculum that can help you teach in this area. I have no disclosures. So we're gonna develop a basic approach to health disparities and health equity curriculum. I wanted you to understand that you need to devise a program that has diversity, equity, and inclusion embedded in all those education activities. And I'm going to list some educational approaches and resources that you can use to achieve these goals. As a framework, I'm going to use this approach. It's a well-established approach for developing medical education curriculum. So I'm going to follow this path to kind of help you develop your own curriculum. You can also use this pathway. First of all, so what is the problem that we have? Well, we need to develop resident and fellow education in health disparities in epilepsy, health equity, and we need to make sure that this is interconnected with diversity and inclusion. Currently, you may have no curriculum. You may have some lectures given by some of your faculty, or your sponsor institution may provide some of the lectures that then your residents and your fellows or your faculty may get. Unfortunately, recently, this curriculum may have been banned in some states. And I can assure you, though, that we can feel comfortable in the fact that, as we know now, these residents, fellows, and faculties are employees of a health system. So under EAOC, you actually can teach professionalism, you can teach about diversity and inclusion, and that is not something that can be state regulated. So all this teaching can still happen for your residents and fellows and faculty. In terms of what is the ideal approach, well, you want to establish one curriculum that teaches about health disparities and health equity, but you want to make sure that the faculty is involved, and you want to make sure that the goal is to make sure that the patient, the epilepsy patient, gets better care. So I want to note that the ACGME actually has noted this, and if you look at the milestones, specifically in system-based practice, they need you to become competent in the knowledge of population and community health needs disparities. So it's very important that in the community that you practice, you become adept about what are the health disparities that occur in that community and that minoritized groups of patients that you may take care of in epilepsy. And to actually graduate, you should be knowledgeable of that group. That means that the faculty has to be knowledgeable, and then that means because you're the ones teaching, and that residents or fellows should do it. But they also added an interpersonal communication skills, which I think is critical because it talks about a very common barrier, which is patient care, language, English proficiency, talking about disabilities, health literacy, cultural humility, which Dr. Etienne mentioned. Those are all things that actually need to be taught throughout the course of your residency and fellowship. And again, sometimes a lot of our faculty haven't been taught that. So it behooves us to create an educational opportunities for all this to occur. So in this example of a target needs assessment, you definitely want them to understand what health disparities and health equity is. And even though it seems simple and it seems straightforward, if you really dive deep on this and ask your faculty, sometimes more the faculty than the students, unfortunately, they have less of an understanding what health equity is, and this confusion about what's fair and what's not fair and what's equal. It's not clearly understood, and the point of having health equity as the highest achievable healthcare for all is not understood, and there seems to be a misunderstanding on who's getting and what's getting and fairness. So that is actually very important. You need to really enforce the value of diversity and inclusion. And of course, like as I mentioned, you want to make sure that the epilepsy health disparities in the groups that you work with are addressed. I used to work in Philadelphia, and the majority of my patients were from Puerto Rico. They spoke Spanish. They have very different barriers than the patients I take care of now in Baltimore, which are mainly black. And the Hispanics that I do take care of also have different barriers because they're not from Puerto Rico, so they're not US citizens, they don't have insurance, so the barriers are very different. So you really need to become adept at knowing what are the barriers that your patients may have and what are the sources that they may have to be treated. And then you want to make sure that diversity and inclusion especially is in the structure of your fellowship, of your residency, and your faculty. I'm going to talk a little bit more about that. So you need to know what is the audience. If you're going to talk to your residents, you may only have 3 years to do it. If you have an epilepsy fellow that is also doing a neurophysiology, EEG fellowship, maybe you have 1 to 2 years. If it's the faculty, maybe you have a little bit of more time, and we do spend, lectures to the faculty or wellness faculty lectures that are more interspersed than the ones that we do to the fellows and the residents. You may have a problem if you have a small program, so you need to You may not have so many faculty that are experts in this, so you may have to leverage associations like AAN, AAMMC that have lectures that are recorded, and you may have to get creative with this. You need your share to be involved. They really need to support you. They need to give you the time. They need to give you the resources. They need to help you with this. Your division director, especially in the Epilepsy Center, should also give you the time, maybe gives you time for the faculty in the epilepsy division meetings, or set aside precious time so that the faculty can actually get the teaching. Your core faculty, they need to be engaged and believe in this so that they are willing to take the initiative to learn, but also to teach. Your program director, of course, is critical for this. Hopefully, because the ACGME kind of mandates this, and there's a lot of language in the WebAS application. When you fill it out, the program director actually needs you to, or somebody to be doing this work. So it's either going to be on them or somebody in the faculty. And of course, if you have a vice chair of diversity, a DEI officer, a committee, or a DEI champion in your department, they can really be very helpful in developing this curriculum. I just want to mention, to avoid the diversity tax, usually we don't have that many underrepresented minority faculty, but they shouldn't fall on them to give all the lectures. It shouldn't fall on them to lead all the workshops. It shouldn't fall on them to create this curriculum by themselves, because it really shouldn't behoove them. And I'm sure they have a lot of other things on their plate. So what are the goals and objectives? You want to have a broad goals and objectives. You want to talk about the big picture: health disparities, health equity, understanding social and structural determinants of health, and how they interrelate with health equity. Self-management, self-efficacy programs. How are these programs like Project ECHO and other programs can help you in taking care of these patients? How is diversity and equity? How is having diverse faculty members, diverse residents and fellows help you in achieving the goals of taking better care of patients? And of course, you want to be more specific. Focus on the community and the resources that you have in your community. So let's go about what are the strategies, educational strategies. You can use the classic lecture-based strategy. So I always give a lecture on health disparities and equity. I take my time to really talk about, like Dr. Etienne, talk about what race really means and the social construct, but what it really means and what is the difference between race and ancestry. And believe it or not, there's a lot of confusion about that, because there's a lot of racial studies that somehow, some way pinpoint genetic underpinnings to a disease, when it's really very, very rare that that's the situation, but it could be, especially if you look at ancestry. It's a much better way to look at genetics based on ancestry or where you came from. You want to teach, like Dr. Etienne said, cultural humility. I always mention to the residents, I was born in Colombia, I grew up in Puerto Rico, and no matter what, I still don't know everything about Puerto Rican and Colombian culture. I just don't. And I actually probably mess up a lot of things, because now I have like the American culture in bed, so my family sometimes gets surprised at my decisions that I make. So it's all a jumble. So you want to obviously talk about the social determinants of health, and you want to talk about the pitfalls. What Dr. Sturvin was talking about, that maybe Hispanic patients believe in the evil spirit causes epilepsy. It seems kind of silly, but some people in the audience or that you're teaching may say, oh, well, they're clearly uneducated people, that they can't understand the concept of EP, so why am I going to take the time? But it's actually the opposite. You have to let them know that everything that you're showing them, all these disparities, are so that you take the time to make sure that you fix what the problem is. Either it's structural, or when they get to your clinic, you take more time to develop trust, you take more time to try to address those issues, and knowing that, knowledge of that specific cultural, the culture of the patient, and what are the barriers that they specifically have, be it language. So if it's language, use a good translator and look at the patient, not have the translator take care of the patient. So it really will help you do better care, not create stereotypes. So I spend a lot of time talking about that, the importance of language, the beauty of using cultural competence versus cultural humility. Language matters, how you speak and what you tell your residents and your fellows and your faculty. And I don't do this alone. I use resources from the AES, AMC, and my sponsor institution sometimes helps me. I try to focus on the groups that we take care of in epilepsy, especially race-based and Black Baltimoreans. I try to make sure that the residents know about the history of redlining in Baltimore and why the patients end up late to our clinics, the transportation issues. I show them maps of Baltimore that have clear depictions of racial structural redlining that causes them to not show up to clinic and have a myriad of other comorbidities. Again, focusing on the community. And then I have the social worker give them lectures about what are the resources that they can have and they can use, so they become experts on what to use. I would love to have a community health worker, because that'd be great, but we don't. But if you do, that'd be great to have them also talk to your faculty and your residents. And your local epilepsy foundation can be helpful. I do journal clubs. I bring journals on LGBTQ care so that they are aware of what is the gender affirming therapy contraindications, or how do they affect with anti-seizure medications. We do a book club. We recently discussed a movie that I highly recommend called Translators. It's a beautiful movie that's in YouTube. It's only 20 minutes. It's a great discussions to have. And then I do workshops. Specifically, I teach implicit bias training, but that can also be online and can be done through other institutional resources. And I do microaggression workshops, which can be very powerful, also very emotionally producing. So those I would recommend learning from somebody before you start doing them yourself. Lastly, we're role models. So showing them how to be structurally better at taking care of underrepresented minorities, minoritized groups. So use templates that maybe talk about social determinants of health in your clinic, so that they're an epic, so you know that this person has a high burden of that, that remind you to spend more time with them. The resident and fellow clinic has always been a place where in a lot of institutions, patients are shoved in that are either too complicated, have poor insurance, or patients that necessarily not wanted to be seen. And it ended up being a lot of minoritized groups that end up in these clinics. Make sure that your structure is not that, and that either you get rid of that, or you make sure that the specialists can get there and that they have a way to see the specialist, so that they don't disappear into this resident fellow clinic. And there's a lot of literature on this. Correct use of translators. I make sure that the root cause analysis in M&M has a social determinants of health embedded in it, so that you know that even before this patient had that near miss, that something in the social determinant of health helped produce that near miss. So not speaking English maybe was one of the causes for that near miss. QI projects should be involved in health disparities. Make sure that there's research inclusion, that you try to make sure that not only you have demographics of all the racial groups that are in your community, but that when you do write a research paper on it, you don't forget to discuss the differences that you find by race. And even if you find that Hispanic patients suffer less from a condition, that can be helpful, because maybe we don't have to focus on that disparity, on that specific reason, and we can look at other things. So even when some minoritized groups do better, that's helpful. And it's also helpful understanding why, because maybe that can teach you how to do other areas that we're not doing as well. Be an ally of your residents and fellows and faculty, so when there's microaggressions, know how to act. Develop your faculty. It's very important to easily answer the question, how do you address racism? Make sure that everybody in your department and your faculty knows how to answer this. That is a really easy way to know if you're really doing a good job in your department. If you're recruiting, diversity in your department is huge. These are people that can teach other members of your faculty what are the cultural norms or how these patients react, and then it normalizes the care of other patients in the same groups. So target websites, give awards for underrepresented minorities, be active in social media, have your faculty attend the meetings for underrepresented minorities, partnered with the sponsor institution to make sure that there is things that you can offer this to recruit these doctors. Be active in the LMSA, Latin American Student Association, Student National Medical Association, and White Coats for Black Lives. These are just examples of things that you can do to recruit. And finally, when you evaluate, make sure that you do written reflections, open discussions, be non-judgmental, and sometimes try to be open to anonymous opinions, because some things can get pretty emotional. These are resources that you can use when you, hopefully if you want to use them, they'll be here. And lastly, so use a 6-step approach to develop your curriculum. Leverage the resources that you have in your institution, in AES or AAN or AAMC, and understand that this is a long, lifelong education process. You're not gonna graduate and be excellent diversity or have it's never gonna end up. This is something that you have to continue doing to your faculty, that your residents are gonna continue to have to do on their own, and your fellows too. Thank you.
Thank you. Camilla, stay. Thank you. I'll invite all the speakers to the podium, and I also want to tell you that the leadership of the American Epilepsy Society takes this issue of healthcare inequities in epilepsy very seriously. The incoming president, Bill Theodore, is joining me in a task force to address these, and the other two, the current president and the second vice president, have also come to this symposium to demonstrate AES's support for this issue and its engagement. So guys, come up. And so questions, comments, and concerns. We set aside all this time to focus on solutions. So I want to hear from the audience.
Thank you for this really fantastic panel.
Hold on, we can't hear you yet.
Say that. No.
Thank you for these really fantastic talks. You brought up so many inspiring ideas and just a lot for us to be challenged by. Thinking about telemedicine and disparities, I think at the beginning of the pandemic, as we switched to telemedicine, we all kind of thought, hey, this is great, it'll reduce disparities, everyone will have access to telemedicine. And then now, at least in my own clinic, I'm noticing that the really privileged patients are the ones who are on time, they have a great telemedicine setup, and then our disadvantaged patients might not be able to get a video connection, they might not be able to, step away from work. I was wondering if anyone could speak to, do you think telemedicine is a force for increasing or decreasing disparities, and how can we better use it? Thank you.
Hello, can you hear me?
Yeah.
Yeah, so this is my personal view. So I think there's two sides to telemedicine and technology in general. I mean, we know a lot of times these minoritized groups that we just spoke about tend to be left behind when it comes to technology. I know when I started using telemedicine, there were certain patients that would be on a flip phone. They couldn't really, they just didn't have these apps or what have you. So the positive of telemedicine is I see it as when you talk about these clinics that are 1,000 miles away, if you need to go for an epilepsy surgery consult 9 hours away, you could do some of the initial consultation through telemedicine. And then eventually you get to the EMU, you get to the, some parts have to be done in person. So to actually expand our reach, to reach these far out places, I think it's extremely beneficial. The only concern I have is that we don't want to all of a sudden make that the default and say we're not actually gonna, the work is done, El Paso's taken care of, so forget about it. We got telemedicine for that. Why should we get the other two epileptologists there? But no, we want to still work on getting a real long-term solution and not just saying this is the Band-Aid. We're going to just use telemedicine.
Yeah, I have a, is this on? I have a question for the whole panel. One thing that I think we need more research on is how much disparities are alleviated by improving insurance access and what remains due to inherent sociocultural factors such as racism and cultural disconnects.
Well, I would say, I don't know, can you hear me?
Yeah.
I would say that access is usually, if you see so that Venn diagram that Dr. Sirven has, it's usually a big bubble like that is talked about. And I think it's true that access is there, But there's a lot of studies that have shown that even when the patient reaches the EMU, for example, or reaches a tertiary epilepsy center, African Americans are still not getting epilepsy surgery. So I think it's not one either or. I think definitely access is a big part, and showing that picture of the mountain and what we see. So part of access is sometimes getting to us, and there's a problem there, and we need to address it. But when they get to us, even when they get to us, there's other issues. So there's trust, there's fear, there's cultural issues. So in our small realm of what we do have to train ourselves in improving trust, improving the way we communicate, improving the way we take care of patients, and while we advocate or let other people advocate to get the harder things, which is getting access, or maybe doing a little bit of both. But I think it's not either or, but definitely I think it's not just access. There's a lot of it to do with us. And honestly, physician bias is prevalent, and because it's unconscious, we don't really know that we're doing it. Yeah. So we really need to learn how to talk to these patients. There has to be more research on that and how to build trust. It's just huge.
So actually, to me, that's very important, because those issues which you just discussed are things that we in the medical community can do, whereas providing universal health insurance in the United States
Absolutely.
Is going to be a much longer struggle that unfortunately probably will not be achieved in my at least lifetime, hopefully in yours.
I agree.
Question?
Insurance access, there's two things that are very challenging to do without insurance. One of them is EMU monitoring, and the other one is surgery. I work in two different clinics. One of them is a private clinic that takes all insurances, including Medicaid, one where most patients have no insurance at all, and there's a lot of immigrants, and there's something called a gold card, which I think is unique to Harris County, and the big barrier ends up being things like EMU and surgery. And I think that that's something that without insurance is very difficult to achieve. I found your talk fascinating, being in Texas as well, in terms of the safety net and how different it is among states. But I think, in some cases, just talking about the one clinic that I work with, which is mostly Hispanic patients, a lot of non-English speakers, we always find a Spanish-speaking resident or a Spanish-speaking attending. And I think there, the big barrier is more insurance. But, I also like what everyone spoke about, cultural humility. I also can't claim to understand everyone's experience, even as someone who's Hispanic, or I can't understand, all the challenges that the Black community faces, for example. And that's a big part of it. Certainly diversifying the workforce is huge, but I don't think it's quite enough. I think both are major issues that need to be addressed.
Go ahead.
I just wanted to first thank you all for being here. It makes my heart happy to see that this is happening in a big stage this year, and all the wonderful talks that were given. Back on the telemedicine talk, I think that one of the things that are not discussed as much is the use of care coordinators and social workers in our communities. For some reason, at least in Chicago, I also take care of a lot of Spanish-speaking patients, and we see sometimes care coordinators come with families with private insurance, and that they have all the resources. They don't need that. They don't need help calling to make appointments or coming to clinic or doing telemedicine. But our patients that don't speak the language and don't have the resources do. And so whether at one point we could prove to the system that would help outcomes and that it would help with times and adding to the point of giving more time to these patients and allocating more time for us to take care of them and helping them get there. So I think ideally telemedicine is not going away. We need to figure out a way to help these families get there too so that the gap doesn't get larger. Just a comment. Thank you.
Reactions?
No, that's such an important point. There are a lot of different solutions and other types of, I hate the word provider, but a provider, if you will, that is non-physician, non-nurse, not kind of that lives within community and can be helpful. We've seen it, like I knew when I lived in Arizona, they had promotoras, which kind of went within church and community in these smaller places for Hispanic patients. They're all part of the solution, and that's going to be the key. The problem is so vast that it's all going to be everything that we say here.
Go ahead.
Hi. Thank you so much. Those were wonderful talks. My name is Lynette Sadlier, and I'm from New Zealand. And I think it's just very sad that there's not a lot more people in the audience listening. But I just thought I could add some insight into just to talk to some of the points about insurance, et cetera. So New Zealand is a public health system. It's equitable from a point of view of everybody has access to the same health system. However, we definitely still have major health disparities. And socioeconomic impact goes far beyond your access to, when I say the amount of healthcare you can access, because you still have to access it. And so if you can't get that time off work to go to that free doctor's appointment, or you haven't got a car to drive to pick up your free medicine, all those things still have significant impact. And I think, so the larger socioeconomic status of individuals has a huge impact on the health inequities, as does the structural racism within your health system, regardless of whether it's universal. So there's a lot of steps and a lot of things that have to be considered. And don't get me wrong, I think it would be great if the Americans all had a public health system coming from one, but that won't solve everything.
Yeah, no, I think that's an excellent point, and it's just a reminder that when we talked about whether there are many structures that impede access, care, many social factors, and so each patient, you can't assume just from looking at him, oh, he's Hispanic or she's Hispanic, it must be this, or they're black, they must be that. They might have the health insurance. Another factor could be at play that's impacting their ability to care. We talked a little bit about that coin model. One of the things I didn't get to say was, when people are if you're on the bottom of any of those coins, one of the things that ends up happening is you become an expert at all the bad things that happen from being in that coin, whether it's because you're in the LGBT community, whether you're a woman, black, Hispanic, low income, rural, you start to know all the nuances and all the problems that happen. But on the other side of it, what's really interesting is if you're on top of any of those particular coins, you're often completely blind to all the disadvantages that come from being on the bottom of that coin. And so a lot of times you'll actually deny that that it's even a problem. And so what do you mean being a man is an advantage? I mean, what are you talking about? What are you talking about equal pay? We all get the same thing. It's really hard to actually perceive it, and people will actually deny it that it's even a problem. Well, you have health insurance. What do you mean you don't have access to care? And so those are like really important nuances you just brought up. Thank you for that comment.
Yeah, can I add on to that? Thank you. That was perfect context. So another piece that we're really trying to drive home here is that community engagement to really get at those points, right? There are a lot of nuances, and if you don't ask the specific community, what are the barriers? What is preventing you from adhering to your medication? What is preventing you from making it to your appointment? Then you are not going to necessarily know and be able to address that. And not only that, but to find out for them what are the meaningful outcomes for them, right? So that you can, the research that we're trying to push for here in the initiatives that we're promoting now is really the community-driven solutions, community-driven interventions, so that you are putting the people first, right? That it's not just about what the broad assumptions or the broad health disparities that exist, but really looking at either a geographical community, a cultural community, or whatever your particular area might be, and really addressing their specific needs.
Yes, Serge Pierre-Louis from Chicago. This is an excellent symposium, and I agree that I would expect that in the future we would have much more participation of the audience. I have a question for Dr. Etienne. Thank you for your excellent presentation, but you have painted such a gruesome picture of what the problems are and how far back in history they go. So that the question is, even though we've seen in the last few years a lot of effort, addressing diversity, inclusion. Are we doing it the right way? And how do we make sure that we can measure the different interventions, and how can we tailor them to different geographic areas in the country? And for example, does the Epilepsy Foundation have some guidelines on how each center should approach those problems and make general recommendations? And are you satisfied, for example, in your center? Are they doing all the right thing to solve those problems?
Yeah, great question. I'll make a few comments and I'll let other people weigh in also. So when it comes to diversity and inclusion, I'm currently the Vice Chancellor for Diversity and Inclusion at New York Medical College, and one of the things I made clear when I took the position was that there would be no minority tax, and that it's not all me. And even when applicants come to visit medical students, I say, if the first time you hear anything about diversity and inclusion is when you see me, then that's not part of the institution. So it has to be within all realms of the institution. So if you have a research, there has to be a D&I component to it. When we talk about education, it has to be embedded in there. Clinical, everything has to have the D&I components that Dr. Gutierrez kind of mentioned during his talk. So that's, once it's embedded into the system, remember when I said before, a systemic problem, a structural problem requires a structural solution. It can't just be a bunch of patchwork to try to get through. I think I'm content with some of the work I've done, but there's a lot more work that obviously needs to be done, really at all levels. And like you said, when you say that even this particular program is not well attended, I can tell you, the stuff we're discussing here is, if you might know, 80%, well, nobody said it today, but about 80% or more of people's health outcomes are from these social determinants.
Right.
We're talking about it in here.
That's right.
In another room, we're going to be talking about some other things that are extremely important, but won't have the level of impact on our patient outcomes as what we're talking about in here. So if we want to be happy, we do have to fill up this room and get all the members to understand all the research you're doing, it comes back to this, what we're talking about here.
That's true.
Yeah, I would agree with that. I know the next room, they're doing frontal lobe epilepsy, but that's a very small problem.
Hi, Fred Lado, and in this case wearing my NAEC hat. I'm thinking of how do we sort of create incentives and carrots and sticks to sort of drive change. And I can think of two. One is payer codes, and there are payer codes that exist but aren't compensated, like mental health care, and there are some codes that don't exist, like care coordination, that would allow programs that want to do these things to get more involved. And then there are regulatory things, NAC accreditation, for instance, where you have to do some things in order to become an accredited center. And I think I would sort of ask the panel in your collected experience, but also the task force that Dr. Kapoor is leading, if you could sort of come up with these actionable ideas. What do we put in place as a first step in terms of what do we ask for in terms of payer codes? Where would that move the needle in terms of providing services that aren't easy to fund right now? That's a big challenge for a lot of the things you described. And so on the other side, the stick, the regulatory things, what do you need to be doing to really be considered a center of excellence for epilepsy care?
I would say when you see the algorithm for epilepsy surgery and the NAC asks for a neuropsychologist, I always have thought that there should be a social worker and a community health worker as part of that algorithm. Because there's always this one part that you see in the diagram that say it's not going to proceed due to social issues. What does that mean? And while there's some social issues that I can tell you in minoritized populations are not going to be fulfilled, because these are the same patients that need to have their job to be able to take care of their family, so they can't go have a surgery that's going to leave them, or even go to the EMU for a week, and they can't. They don't have anybody to take care of their kids or anybody to make money, so they just need to work. But if we have at least a social worker, a community health worker, like maybe they can somehow help them figure out ways to address those issues. Sometimes it's not even fear or trust that leads them to not have surgery, it's just that they can't. So we need to have them have some sort of help with that. And so a lot of those people that disappeared into these social issues may come back to be surgery candidates, maybe do well, and then they can return to work and they can take care of their family. So I really think, I'm always wonder why that's not a component that is asked for. And certainly not all patients need that, but there's a lot of them that need it. It's probably the minoritized patients that need it the most.
Hi, I'm Melissa Miller, Department of Defense. So I'm hearing a lot of need for policy change, and one of the ways to do that is through more evidence. We need more research in this space to then bring the evidence to policymakers, to care providers. But there's not a lot of people doing this research. How, as a funder who is very interested in research in this space, how do we get more people into this area of research?
So I'll begin by saying a primary driver for me to organize this was to bring more, tell young people that this is where the future of epilepsy research is. And standing up here and saying that those who study this problem and successfully, and NIH is here, so people used to say, oh, you can't get NIH funding for doing this research, but I made sure that NINDS is here representing it. And I think a lot of young people are missing out on an opportunity if they don't work on it. Yeah. That's my sort of soapbox.
Yeah, I'm going to give you a brief example. Earlier this year, I took over as the head of our neurology group in a community hospital. And one of the first things they've always been proud of how great we do with stroke care. We get all these TPA, but everybody's always giving high fives. One of the first things I said is, okay, let's look at our numbers by race and gender and age, et cetera. And come to find out, 25% of the patients who had stroke at the hospital were Black, Hispanic, and Asian. And at first what they told me, we didn't need to even look at it because we give equitable care. And then we looked at what percentage of those people got TPA. It was 0. So Black, Asian, Hispanic made up 0% of the TPA cases. And all of a sudden, they were interested. Everybody's interested now. Whoa, what's going on here? And what we want to make it clear when we go back to the curb cutting idea is 0% of those patients who are Black, Hispanic, Asian not getting TPA, I can guarantee you almost that there's even more white patients who missed out on TPA for many of the same reasons that those patients did not get the TPA. So by actually finding out what is the rationale, what is the reason for each of those people not getting the TPA, you've cut the curb, and all of a sudden, more people are getting TPA at your hospital. That's what this all translates to. It actually improves the health of our community. One of the senators, I think I forget which one, said, oh, the U.S. Mortality rate, it looks bad, but if you take out the Black babies, it's actually really good. It's like, no, well, because the fact that Black lives matter, you have to actually count them, and you have to come up with structural and solutions to actually improve that health, and it improves the overall health of the entire country.
I would want to add, well, actually, I don't know if you're going to talk about your poster, Dr. Shea.
Oh, no, I was just going to have one comment about how to get more people interested in this. So I think that this area of research has been kind of going on for a long time, but only recently has there been more interest in it. And as a result of that, I think a lot of people aren't very familiar with it, familiar with the lingo, familiar with what questions to ask, certainly familiar with interventions as opposed to describing disparities, which I think is the step we're all interested in. What can we actually do to make this better, right? So I think what we really need is more mentorship and people who know what they're doing to mentor the next generation of researchers.
I just really quickly want to add a call to action. And Dr. Shea made a really good point with the Pediatric Research Consortium. She looked at all these papers and she found out that there's a lot of research, not in neurology journals, but in other journals that talk about race and sociodemographic issues. But the truth is, I think that the call to action, I think, is that any research that you do should have a race column and not just, you know, black, white. It should be non-Hispanic white, Hispanic black, separated by groups. If you are able to separate the Hispanic groups by Mexican, Puerto Rican, or it really helps, because it really then teases out what are the issues. Just like you said, if we don't look at it, we won't see that there's issues. And every paper has limitations. Every paper has structure. The structure of demographic tables in every research paper should have these things. And guess what? Sometimes we're going to find out good things, that there's opposite disparities. There's groups are doing better. Again, you can learn from that too. So every research paper, the low-hanging fruit should be there. Every editorial journal should say, where is the demographics on that? And why are you not, maybe your community in Baltimore, for example, where I live, is a 60% black city. The patient population in that research should be mainly black, not white. Why is that not happening? So I think that's a big low-hanging fruit that we can all just start doing.
All right, one last question, and then we have to stop.
Okay, can I just comment briefly
Sure.
on the research piece too, because I just wanted to acknowledge, I agree with you completely that we want to do more and fund more research in this area. And I think one of the ways that we're trying to do it also is thinking about building these multidisciplinary teams, right? So if we don't have a lot of neurological disorders researchers who have experience in working in certain populations, or they don't know exactly what social determinants of health are, you bring in that expertise, right? You build those collaborations and you expand the field by doing that, and you expand the expertise so that, you know, each one teaches one, right? So I think that's one of the big areas that we're focused on.
Thank you. Thank you all for your excellent talks. I'm Hiba Haider. I'm at the University of Chicago, and we serve the south side of Chicago, so disparities are front and center in a lot of the work that we do there. And I wanted to kind of piggyback on a couple of comments already made, one by Dr. Lado about advocacy and the regulatory piece, which I think for epilepsy and status epilepticus as a subset of TBI has really lagged behind. I'll give you an example of patient with NORS or FIRES, for example, who gets admitted, and we do any number of heroic things to stop their seizures. I won't even go into the details here, but essentially this patient ends up getting declined from over 120 placement facilities for long-term care because they're on Epidiolex, and even though in the state, possession and use of marijuana is legal and Epidiolex is FDA approved, from the federal level, because it's still scheduled to where CMS-funded facilities may not be able to accept patients who are on a specific agent because that agent needs to be self-administered. They will not take the responsibility of actually administering that specific agent. So this patient languished in the hospital for months and months and months just for that. And to the degree to which that undermines the trust of patients and their families with the healthcare system, I mean, the healthcare system completely failed this family. So that's one thing. And the second thing is, I think we have a lot of research already, and certainly we need to continue to do that. But a lot of work in disparities, I think one thing that we could probably start thinking about and following in the footsteps of, say, the stroke community is focus on the delivery and the implementation of care, because that's a big piece of what's failing. So I'm curious to see if there's any initiatives ongoing, collaborations in the epilepsy space related to implementation science or healthcare delivery that would be, or if we should be looking into doing something like that.
You see a deafening silence here.
Yeah. Well, I can say, as part of the Pediatric Epilepsy Research Consortium, this is something that we're working on. We've kind of gone from, this enormous paper scoping review looking at kind of what information is out in the literature, and now we're moving into, what are things that we can do about it? And we have a collaboration. I think PERC has something like 70 different institutions. And so, I think, just like you're saying, we're starting to transition from just identifying where the disparities are because they're everywhere, and now moving into, what can we do about them? And I think, you do need multiple people coming together and working together to find these solutions.
As I mentioned, we have a task force to come up with a set of recommendations, and the promise has been, next year when Bill's presidency, he can announce them, at least some measures that we can get moving. We'll find out how many of them work and how many of them are completely useless, but we need to try them before we know whether they work or not. And the phase of experimenting has to begin, and I'm so glad that NIH is willing to fund that. And there are lots of hypotheses underlying these disparities, right? And with these hypotheses can only be tested by implementing a plan and seeing whether it worked or it didn't work quantitatively. I want to thank you all for coming. This has been a great session. Thank you. And there are multiple other sessions on disparities in epilepsy throughout this meeting, including the annual course, I think. All right, thank you.